Chair. For the Professor first, I want to dig down a little bit into the surgeon's aspect, because my crude understanding is that surgeons were obviously redeployed and haven't been doing as much cutting as they'd like to do, so they're raring to go. But part of the problem is the anaesthetists have been moved across to the intensive side to deal with COVID, and then are coming back and are washed out. How much of a characterisation does that fit? Where is the bottleneck from the surgeon's point of view?
I think it's a combination of the two. Clearly, we started from a low base in the sense that in anaesthesia, about 10% of all consultant posts are vacant at the moment. So most operations need anaesthesia. There is one of the, if you like, innovations is trying to see how many surgeries can be done with local anaesthesia and variations on that. But nonetheless, you can't get around the fact that you need a surgical team. The surgical team will not just be the surgeon, will be the anaesthetist and the theatre team, and all of those have pressures. Coming back to the surgeons, this retention issue is really, really important. As Anita has brilliantly pointed out, surgeons don't grow on trees. We can't buy them very easily off the street. They take a long time to make, and so the ones that are there, we have to work really, really hard to try and keep. And as you'll know, there are lots and lots of pressures there around pension contributions, lifetime allowance, all that kind of stuff. So if you're going to say to, let's say, a relatively senior surgeon, we'd like you to do weekends and nights, and they say, fine, and even if Anita persuades the authorities to pay them a bit more, they'll say, actually, in certain circumstances, it's not worth my carry on doing this.
Is the pension issue resolved?
No.
No, it's still ongoing.
It's still a massive issue. It seems to have gone
very quiet. I saw there was a temporary measure put in place to cover it off. But given the fact that most NHS surgeons are also the independent sector as well, so if you're looking for the independent sector, you need to cross over. We want to incentivise people to come back. It seems that the pensions one is a sensible investment to solve, to be able to get this problem. And I think you can sell that to the public to be able to say, this is the reason we're incentivising people. They're not going to do it off their good back. They've had a hard pandemic. How close to getting resolved from your aspect is this? Where's the sticking point there?
From what I've heard in the meetings I've attended, there are still major roadblocks in the way. And you talk about surgeons particularly. I think this applies to all medics. And we mentioned the independent sector too. The independent sector relies upon nursing staff very often from the local NHS hospital, doing shifts and so on. And so there is a finite resource, and you can't just shift it to the independent sector. Although during the pandemic and now subsequently, the independent sector has provided a safe haven to a degree. There have been safe sites on which surgery can be carried out, including James's, as he pointed out.
And you said surgeons don't grow on trees. Can you talk about the impact on the training it's had on surgeons? Surgeons need operating time and are managed on the number of cases they do, the hours they do, and the number of procedures. Clearly, COVID's going to have impacted that. So we've had 18 months of losing SHOs and registrars with cutting time effectively. How has the college managed that, and what can be done to help that?
We're just about to see the figures on where our surgical trainees are in terms of their numbers to allow them to become credible surgeons. And around 50% of surgeons in their last 2 years of training do not meet the requirement in terms of numbers and experience to graduate out of the training program. So even then, you say we've got this pipeline of new surgeons about to come along, but they are greatly under pressure because they haven't had enough experience. What's being done about it? We're measuring it. We're trying to assess the scale of the problem. We are looking at issues like AI, like simulation training and so on. Those are all pretty good early on in your surgical career. Later in your surgical career, there are the whole subtleties of the individuality of a case and its complexity, which needs to be appreciated in real time in a real patient, obviously helped by an experienced consultant surgeon. But you're absolutely right, it's had a massive effect on trainees. One of the things we're concerned about is also retention of trainees. There are some trainees who've become deeply disillusioned, and there's another tribe we need to work really hard to retain too.
Thank you very much. Dr. Goddard, if I could come to you. From my experience back in hospital, all roads led to the radiology department, and testing is really, really important. You'll know this from the physicians asking the test, needing CT scans, MRI scans. Do you perceive that to be a bottleneck going forward?
Getting the scans is a bottleneck, so we have lots of people, particularly outpatients, who are waiting longer times to get diagnostic tests. Getting them reported is a bit of a bottleneck, although reporting, because images can be sent around the world, can be done, and then you can have reports done in the middle of the night UK time when it's daytime in Australia, for example. I think pathology is probably under bigger stress, and certainly from the point of view of histopathology, that is looking at the query cancer specimens that are taken is much more of a pressure and a worry. Clearly, at the moment, getting blood tests is a real problem, and it's interesting. So these waiting times are specifically the 18-week times. Within that group, about 2/3 of people are under the 18 weeks. They're still on the waiting list, but they may be waiting for tests. And because we're doing we do 1.7 million blood tests a week in the NHS. That number has been significantly curtailed because of the blood bottle shortage. So it seems likely that because of COVID and all the issues it has with the supply chain, that there are going to be added complications which will lead to further delays in diagnosis, because you can't start a treatment and therefore get off the waiting list until you have a diagnosis. So the surgical aspects are really important, and trauma and orthopaedics is the biggest group that are waiting for a treatment. But if you go down, about half that number that are waiting for hips and knees are also waiting for heart interventions, which might be not done by surgeons but are done within cardiology departments and gastroenterology departments for my own specialty. So we have to think about the diagnostic processes, as you've alluded to.
Well, that's and you both highlighted it perfectly, which is what I was hoping you'd do. Because do you think the NHS has a joined-up plan? I always think of Sky Cycling was infamous for taking percentages across weight and the way their aerodynamics. And actually, suddenly, if we make a percentage better on the bottles, a percentage better in the operating theatres and efficiencies, actually we can hit the 120% efficiencies that's being asked of hospitals at the moment. Do you think the NHS has the plan to be able to do that, or putting it together? Because is it coming through to you in your positions on the coalface? Because that's really important for us to be able to say, look, are we seeing this joined up? And all these problems, you've got a litany of list already off the top of your head. That list, I'm sure, would be tenfold. But that's really important, because until someone's pulling that together to knock them all out, it becomes very, very hard to deal and break down the scale that we're looking at.
It doesn't feel like there is a coherent plan. I think that the challenge, therefore, is that we are all interconnected. So we know that winter's coming. And clearly winter has been here already. So I was on duty a couple of weekends ago, and because of COVID sickness and because of staff absences, there were no trainees on my ward. And so normally I would go around with the trainee or advanced clinical practitioner. Both were off sick, so I did the ward round on my own. So these are things that are impacting on a daily basis. But during winter, what we'd normally see is that the medical wards get full. We spill over, and my ward, what becomes the winter ward, is normally an orthopaedic ward. So immediately, Neil and his colleagues cannot operate on people who are on the waiting list. I do not see that being any easier this winter, and if anything, I think it's going to be much worse this winter because of COVID and infection prevention that I've talked about before, but also we are expecting a bad flu season this year. Because people haven't been exposed to flu over the past year, so it's likely to be much worse. So I think that the news about the 5.4 billion funding is fantastic news, but let's be under no illusions. This winter is going to be remarkably hard, and it's going to impact waiting lists probably more than anywhere else.
And that leads me to the
last one.
final set of questions for Dr. Henson. Perfect place. It's been set up. A&E is always the brunt and the traffic light of the health service. A lot has been made, we're hearing GPs next week. Can you talk about the experience of what you think primary care and A&E relationship is at the moment? There's that talk that you hear in the newspapers that GPs aren't opening and it's putting pressure on the A&E. They would push back and say, no, it's because of the significant pressures and people changing their behaviours. Does the department have does the college have a position on that?
So we're back at pre-pandemic levels of attendance in emergency departments. So July's numbers were the second highest ever. and our A&E performance is at our lowest ever, so we're at about 68% for type 1 performance. So we are not surprised by this. There was no reason why patients wouldn't be coming back, but there are a number of reasons why we seem to be seeing them coming back very fast. Now, we are seeing patients, yes, who say they can't get face-to-face appointments with primary care, but we're also seeing primary care seeing patients who can't get their surgical treatment, can't get their outpatient treatment, can't get their diagnostic treatment. So it's not about one side of the service versus the other side of the service, and I think